Okay, it's important to understand about measles that it is highly contagious. 90% of people who are exposed will develop it. And moreover, this is an illness that we thought once was controlled. We have twice believed that we have eradicated measles, as you can see in this slide here. When the measles vaccine was licensed in 1963, there was a dramatic drop from over 500,000 children per year developing measles over the next several years, so that by the mid-1980s, there were hardly any cases of measles in the United States. However, in the late 1980s, there was a rise. And at that point, it was realized that some of the patients who'd been immunized had had a decline in their antibodies to the point that they were again susceptible. So at this point, the second dose was recommended. This had a very good effect on decreasing the measles rate in the United States. And by the year 2000, with the help of public health efforts, measles was actually declared eliminated from the entire Western Hemisphere. This means North, South, Central America, all eliminated measles. And there was, and the levels have now been quite low. However, there has started to be a rebound in the measles, particularly noted in 2014, when you can see that there was an outbreak in the United States that involved over 800 people. And again, in 2019, a large number of cases throughout the United States. Following the quarantine periods for COVID, there has been a rise again in measles. And once again, the CDC is very concerned about measles at this time. So this shows what has been happening at the end of 2023, where there was a slow buildup and then a dramatic increase in cases. And now, once again, in 2024, there has been over 251 cases. Very important in thinking about measles to realize that this is a stereotyped illness which causes severe illness in all affected people. There are no inapparent cases of measles. The course is very stereotyped. This is often fatal in developing countries, and even as in the United States, the mortality rate for measles is still said to be 1 to 3 per thousand, which is really a very high rate. The incubation period is from 7 to 18 days, so it may be very long. And the onset of disease is with a very high fever, cough, runny nose, conjunctivitis, and photophobia. These are children who look much sicker and adults who look much sicker than patients who have simple colds. Their fever tends to be higher, their cough is worse, their runny nose is more dramatic. The closest thing they might look like would be like people with influenza, but perhaps even more severe. So there's little to distinguish it from a severe cold except the high fever and the severe involvement. But by the time of 3 days or so, little spots may appear in the buccal mucosa. These will be overlooked if you don't look for them, and they will also be hard to see because they're small. The rash tends to appear around about day 5 to 7 of symptoms, and the fever persists for 3 to 4 days after the rash appears. Fever falls and the rash fades. So the clinical case definition is shown here with a high fever and rash and at least one of the 3 C's. This is a good example of how a child might look at the very beginning of the rash. The rash tends to appear first on the forehead and on the face. At that time, the child is still probably tearing and coughing and sneezing, and is, of course, still febrile. And they have been sick for several days. People at this stage, especially today, tend to make 3 to 4 visits to doctor's offices because they think the child is sicker than they should be with a simple cold. This is a picture of Koplik spots, and those tiny little white spots that may be slightly raised is seen here. You can actually see similar spots in the conjunctiva if you look, and the spots fade rapidly as the rash appears. So when you're looking for the pathognomonic sign of measles, the Koplik spots, you have to be quick. Another example of Koplik spots, they may be a white spot, they may be a white spot with a red halo, or the white spot may not be that apparent. So get in the habit of looking in with your tongue blade in the cheek mucosa of the patients who have fever and cough and coryza. This is a good example of the rash being quite apparent on the face. The rash of measles is the kind of thing that actually can knock your socks off from the doorway to the room. This is not an inapparent rash. This is a definite raised papular erythematous rash that is coalescent, or that tends to become coalescent in many areas. Good examples are shown here in the slide of the back of a boy. You can see how the rash is often raised. And you can see on this slide of this miserable child how the rash in the face has become coalescent. So these are not inapparent rashes. The conjunctival suffusion differs a little from Kawasaki disease, which you can see below, where you see each little vessel neatly outlined, but the conjunctival involvement in measles, especially in the first few days, may just be a generalized erythema. So the rash, as we already mentioned, starts in the face, spreads downward, is macular papular, raised or flat bumps, not usually itchy, and you may still see the Koplik spots. That's an amazingly good picture of Koplik spots there. Very rare to find something just that dramatic. Measles' skin tone can be a problem. It might be difficult to see the erythema, and the skin may appear just as if there's hyperpigmented macules and papules. And later on, in darker skinned individuals, there may be some hypopigmentation at the areas where there had been rash. The timeline of measles are that the dramatically long incubation period is followed by the onset of fever and -4 to 1 days before the rash occurs. The illness is actually rarely diagnosed at the sign of before the rash appears, unless you're in an outbreak when you're trained to look for the severe signs of coryza, cough, conjunctivitis, and high fever, and suspect measles, especially if there's been a contact. They could come out of isolation at about the 5th day after the onset of the rash. So now I'm going to present a case that actually Anna Luker and I presented a grand rounds on at one time. So this is an 11-month-old boy with a 6-day history of fever, cough, runny nose, and diarrhea. 3 days prior to admission, he also developed a rash starting on the face and spreading to the torso and the extremities. And on the day of admission, family noticed that he had conjunctivitis, decreased activity, decreased urine output, and they brought him to the emergency department. He'd actually been evaluated 3 times before by his primary care physician and once in an outside emergency department, in all cases with a diagnosis of an upper respiratory infection. So the physical findings on initial presentation were that he didn't actually have a fever exactly at that time, although he did later. His heart rate was 156, his respiratory rate was definitely elevated. And he was tired of hearing fussy but consolable. He had bilateral conjunctival injection, he had a nasal discharge, mucousy, yellow, dry mucous membranes, bilateral cervical adenopathy, and respiratory cough, coarse breath sounds, and the rash. This is the picture of the rash in the emergency department on its 3rd day. So his diagnostic workup showed that his CBC was normal, except for slightly low platelets. His CMP showed an elevated liver enzyme slightly. He didn't have very elevated inflammatory markers. His CRP was only 9.4, ESR was only 21. Urinalysis was normal. Rapid flu and viral panel were negative. Chest x-ray was normal. His EKG and echo were within normal limits. Initially, there was concern for Kawasaki disease, which can be a good mimicker. And this is another demonstration of the clinical course. Now we're at the rash side. In the hospital, he had IgM for measles, which was elevated. He was placed on airborne precautions. He was treated with vitamin A for 2 days, and he had gradual improvement with fevers, conjunctivitis, and ulcer in the mouth resolved. He had a persistent cough without need for respiratory support. And he was discharged on day 5 after the onset of rash. And an epidemiologic investigation demonstrated actually 2 additional patients with measles following contact with our patient in the PCP's office. And this is a typical story that an office is a place where people actually may acquire measles and then spread it within their families and in their social group. In this case, all the patients with possible contact were identified and contacted. And it turns out that this child had been, was at 11 months, had not received MMR, but he had flown to visit family in Guam. And while he was there, he had obviously been exposed to measles. So diagnosis depends on obtaining a IgM and a nasal swab, and these can be performed in the health department. If you did a viral culture and pathologic evaluation, you may see giant cells with inclusions in affected tissues. So airborne precautions are needed. This is the most contagious disease that we deal with now that we no longer deal with smallpox. It is at least 8 or 10 times more contagious than COVID and SARS. So definitely airborne precautions are needed. We should do serologies and RT-PCR, and both of these are now available in our health department because IgM testing alone can pose challenges. There can be some cross-reactivity, and there can be some false positive results. So if you have an IgM for measles and there's no local transmission, and the patient not traveled, it may be dealing with a false positive. So swabbing at the same time for the RT-PCR is indicated. So when you're making a diagnosis, you have to consider, as we did in this case here, the clinical, epidemiologic, and the laboratory data. What might confuse you with Kawasaki disease? Well, parvovirus, 5th disease, human herpes virus 6, roseola or 6th disease, and enteroviruses, particularly enteroviruses, allergic rashes, antibiotic sensitivity reactions can produce dramatic rashes, which may need to be considered. Hand, foot, mouth is quite important because it has also spots on the palms and soles, which is characteristic of the rash of measles, but in general is a relatively uncommon finding. And we are now seeing cases of both typical and atypical hand, foot, mouth disease. The atypical hand, foot, mouth tends to have more severe appearance of the lesions, which are more generalized across the body and particularly also appear around the mouth, whereas the typical hand, foot, mouth tends to have rash limited to the palms and soles, and within the mouth having ulcers or herpangina lesions in the posterior pharynx. But the atypical form causes a much more dramatic rash. Ironically, it's actually a somewhat milder illness in general. A fever of typical hand, foot, mouth syndrome may be higher and last longer. And the very dramatic looking generalized rash associated with atypical hand, foot, mouth usually is of shorter duration, and the patient is usually less sick. But in the case of measles, expect that all of your patients will appear quite ill. Kawasaki disease clinically can be a close mimic of measles and was considered in the patient that I presented that I saw with Dr. Luker. In general, measles doesn't have prominent lymphadenopathy or notable lip and mouth changes. Kawasaki disease will have diffuse erythema on the palms and soles rather than the actual macules that you'll see on the palms and soles in measles. But lab findings will definitely help distinguish the two here. Measles, as in the case I described, will have low normal platelets, generally a low white count, and a skimpy absolute neutrophil count, while Kawasaki disease will have a much higher neutrophil count, usually above the limit of normal to high platelets at the time of presentation. They'll become higher later, and much higher ESR and CRP, which are usually insignificant in measles. So we do not yet have a specific antiviral agent for measles treatment. It is recommended that anyone ill enough to be hospitalized should have some vitamin A supplementation for a short period of time. This is based upon studies of that show that vitamin A decreases fatality in low resource countries. So this is the vitamin A dosing. Its potential use in seriously ill patients with ribavirin, but very limited use, and this would have to be available through the CDC. So measles complications. 20% of measles in the patients in the United States will require hospitalization. Associated features are often diarrhea, otitis media. Pneumonia is not terribly common, but very important in fatal cases. Encephalitis also occurs in 1 per 1,000 cases, and death in high resource countries is repeatedly reported to be about 1 to 3 per 1,000 cases, generally due to encephalitis or, and maybe most prominently, pneumonia. Complications are more common in infants, young children, and in adults, but all patients with measles are seriously ill. A funny story here is that when I was an intern in pediatrics and my husband was an intern in internal medicine, he developed measles. Despite the fact that he'd gone to public schools in New York City and had not led a sheltered life in childhood. I had had measles as a child. I diagnosed him with measles, but he was seriously ill. He did have pneumonia, and the internists who were caring for him had never seen anything like it with adults covered with a rash who had severe pneumonia. They had no faith in my diagnosis, so they called a pediatric infectious disease specialist who said, well, of course, anyone can tell, this is measles. Subacute sclerosing panencephalitis is a rare but fatal and progressive neurologic disease. It's a slow virus disease induced by the actual measles virus, not yet reported with the vaccine virus. It has an onset of about 7 years after infection, but it can occur even later than that. And it's marked by mental deterioration, progression to myoclonic seizures, disability, persistent vegetative state, and death generally occurs in 1 to 3 years of diagnosis. So this is a progressive, serious complication. In certain countries that were unable to control measles, they saw a considerable number of people with SSPE in the years following measles outbreaks. So this is just a summary of what we've been talking about. So vaccination, all pediatricians know that we give the live attenuated MMR at 12 months to 15 months. We don't give it before 15 months because of the potential for maternal antibody to interfere with vaccine uptake. Booster dose is at 4 to 6 years in general, but the second dose can be given at least 28 days following the initial dose, and this is considered a full vaccination. But it is the declines in measles vaccination globally that has increased the risk of larger measles outbreaks worldwide, including in our country. So this is really terribly important. And in many parts of the world, measles is a common disease, and popular travel destinations are experiencing measles outbreaks currently at present in the United Kingdom, India, Austria, the Philippines, and more. A typical story, like the patient that we had, is that a family who lives in the United States may travel to another country with their young child, and their child is unimmunized because of his young age. He may become exposed and bring measles back home with him. In those cases, people who are traveling with their young infants should be given a dose of measles immunization from the ages of 6 months on. when they reach 1 year of age, they will need to be revaccinated. So this vaccination will not count because it may have been blunted by the maternal antibody, but it is adequate to prevent this patient from picking up measles when he travels. Currently in the United States, all measles outbreaks have originated from international travel, and the importations most often come from unvaccinated US residents. This is particularly important at this particular time in 2024. So 2024 is now 251 cases that were reported, but this is an old slide. The characteristics of these patients were that 44% were under 5, and 32% were over 20. The vaccination status was they were unvaccinated or it was unknown in 82%. But 13% of people who do know had had 1 MMR dose, and 2 MMR doses was seen in 5%. So as you can see on this particular slide, the importations that came to the US from the US residents were predominantly, particularly recently, in these purple slides, and from foreign visitors bringing it in was less. So in 2024, almost all of our cases and several outbreaks were traced back to US resident traveling abroad who was unimmunized or underimmunized or unfortunately had a breakthrough case. This slide is important because it's telling us that we're not doing so terribly well with immunization uptake. And in fact, in certain schools, this is vaccine coverage at kindergarten, and in certain schools in our state had strikingly low immunization rates. The highest immunization rates in the United States are actually, ironically, in California, where because of the 2014 measles outbreak, which originated in Disneyland and which had a big impact on children in the Orange County region, the legislature of California was bold enough to eliminate the personal belief exemption from vaccination. So there's also high vaccination rates in certain states, predominantly in the East, and in our state, our current vaccine coverage statewide is less than 90%. It is estimated that in order to be free of outbreaks, immunization rates in a community need to be about 95% or better. We've already talked about maternal immunity. So obviously, we now need to review what are the vaccine recommendations for adults. Adults who are without evidence of immunity generally should get 1 dose of MMR, and 2 doses are required for high-risk adults, international healthcare personnel, international travelers, which is a very large number of people, and students attending college or any post-secondary school. It's still allowed that if your birth was before 1957, it was assumed that you would have had measles in childhood. These standards may need to be changed, but these are the current recommendations. CDC is now recommending that all US residents older than 6 months who are going to travel internationally receive MMR vaccine prior to departure if they don't have evidence of immunity. the infants, as mentioned, will need to have 2 more doses on the typical pediatric schedule if they're immunized before 12 months of age. If they are 12 months of age or older, 2 doses of MMR vaccine by at least 28 days. And teenagers or adults without evidence of immunity, 2 doses of MMR vaccine separated by at least 28 days. For people who have had 1 dose, it's prudent that they should get the 2nd dose before travel. Contraindications are severe immunocompromising conditions, hematologic malignancy, chemotherapy, long-term immunosuppressive therapy, HIV, if their CD4 counts are less than 15%, or their absolute CD4 count is less than 200. In general, though, for most people with HIV today, who generally are in better shape than the past, if they're under care and on treatment, they probably should get MMR. History of severe allergic reaction to an MMR or an MMR vaccine component and pregnancy are considered contraindications. So the MMR is generally well tolerated. The common side effects are 15% or less of fever and a brief rash in 5%. Some form of lymphadenopathy near the area of the immunization is seen in 5% of children or in adults. And rare serious adverse events are anaphylaxis, febrile seizures, and thrombocytopenia. But you may actually see this in the 10 to 14 days following immunization. Febrile seizures are interesting because the incidence of febrile seizures after measles vaccination is about equivalent to the incidence of febrile seizures after pertussis immunization, but often overlooked because the fever and the seizures tend to occur later and not immediately after vaccination. Measles itself, the MMR can cause a self-limited rash, which can look a lot like measles. It's not contagious to others, and people who show this rash are not contagious. So it can be difficult to distinguish it from an MMR reaction if in an outbreak, because if the patient had been exposed to measles and was given MMR to prevent measles and then develops a rash, they may be thought to have measles itself. However, this is usually a short-lived presence of rash and not usually associated with the full picture of illness that you see in sick patients with measles. So it is required to report suspected measles cases to the local health department, and the health department in Hawaii will be very helpful. You will be able to reach them by the on-call person at any time, and they will take measles reports very seriously. And they can help with the testing, and actually, in our case, in our state, they actually do the testing. Once you've identified a patient with measles, you need to prioritize identifying the contacts. Exposed susceptible household contacts have a high rate of greater than 90%. And infants aged 1 year have a high risk of severe disease, pregnant people, and immunocompromised. But even a short period of exposure in a waiting room to children with measles will produce measles in the contacts. And as these children tend to make multiple visits before the appearance of rash and before their diagnosis, there is almost always going to be secondary cases in a single case of measles that might have been seen on a returning traveler or in a contact of a returning traveler. So once you've identified that who the susceptibles are, is the possibility of using post-exposure prophylaxis. If you give MMR within 72 hours of the initial measles exposure, it is likely to prevent or minimize the symptoms of a consequent measles disease. If you give it later than this window, it is just going to be a vaccine. It is not necessarily going to give them any kind of adequate help against the measles that they may have been exposed to. You can give immunoglobulin intramuscularly or intravenously. And if you have a high-risk person who's been exposed, intravenous immune globulin at an infusion center is appropriate. So finally, your community vaccination. If school-age children are at risk due to the location of the outbreak and the transmission settings, such as whether it's in a school, whether it's in a religious community, whether it's in any sort of a communal living, all the preschool age children should be given their second dose. And adults in these settings can be considered for a second dose if they'd only had one previous dose. If the infant is less than 12 months of age and the exposed infant is over 6 months, you can consider giving them an MMR dose to prevent disease. And then, of course, if you're immunizing any infants under 12 months of age, their first immunization does not count, and they will need to have their regular immunization series. So just to review this, when there are cases, it's important to identify the probable and confirmed cases as quickly as possible so that you can then provide post-exposure prophylaxis for susceptible contacts. And after you've reported this to the health department, they will help you do this. You can prevent spread of measles in your healthcare facilities by identifying suspect cases early and ensuring high levels of vaccination in your practice. So we now have some time for questions.
Thank you so much. Shall we put the poll up? Perfect timing, never mind. So we'll look through these questions and have a couple minutes to answer the questions. And in the meantime, if anyone has any questions that they have for Dr. Melish that you already know that you would like her to answer, feel free to put those in the chat as well. And while we are running through the poll, I did have one question that has come up so far that I might just pass on to you, Dr. Melish. If a child is exposed to measles And has an MMR is recommended should another MMR vaccine be provided within those first 72 hours?
They've only had one MMR. That would be a prudent thing to do.
And if they've had both, they should have adequate coverage.
Well, they should have adequate coverage. It's interesting that there are people who had 2 immunizations who have gotten measles. But in general, on a community-wide, we have done well with the two immunization schedule in the United States and in other countries. And you know, we did. It's important to remember that we did actually eliminate spread in the entire Western Hemisphere in the year 2000, and following that, we've had these new outbreaks.
Do you know more about those 2 patients that had received both vaccines and fell ill? Nonetheless.
No, this is just data from you know, from the CDC from this year, early cases, and that's just the information that they had.
Absolutely, no problem.
Yeah.
Summer, how are we doing with our questions?
We are.
I answered one wrong already.
Measles is more contagious. Measles is the most contagious disease that we know. It is far more contagious than COVID and SARS. Varicella is more contagious than COVID and SARS, but it's only half as likely to result in secondary cases as exposure to measles. Even in the office setting, many outbreaks have centered around physicians' offices. So if you see a child that may have measles, they should be immediately in a separate room, and that separate room should not be used for other patients for at least an hour after, because it is known that if you put a susceptible in a room that has been recently occupied by a patient with measles, there's enough measles in the air to produce disease in the susceptible. So the emphasis on it is, or question 1 is that it is the most contagious disease. I meant to spend some time on, but I cut part of it out of my talk because it was too long, on one of the problems of measles is that we've learned in the last decade that it is quite immunosuppressive in healthy people for several months after they've had measles. So it isn't just that it's a severe disease that can produce pneumonia or encephalitis, but it is also a disease that is immunosuppressive in healthy people, and they're likely to have more illnesses in the next few months because their immune response is depressed. Okay, so that was I'm not really controlling this screen anymore, so
Not wanting to move to the next slide.
yeah. Well, let's see if I can. Let's see. So this is who in 2024, the most frequent importation of measles into the U.S. comes from which of the following groups?
Summer, do you see most people having answered the question? Oh, perfect. There we go.
So,
It looks like we've done a fairly good job, I think, with this question. We have 86% who voted for
okay.
number one. And that's the right answer, I believe, right?
Yes. Okay.
And then question 3, we have some responses all over the board, so we might need your help clarifying that one more time.
Okay. Trying to move on to question 3.
Not wanting to cooperate, is it?
This slide is definitely not.
You could try stop sharing and then, oh, there we go.
Okay. So answer to this one is 2 and 3. It's false. That doesn't have a high rate of inapparent illness. It spreads widely, but not because of high rate of inapparent illness. And 85% measles vaccine coverage is not good enough. So that's our challenge for us, because we have demonstrated that our community has been combination of increased loudness from the anti-vaccine community and just recovery from COVID and difficulty returning to normal life, I think, has resulted in lax vaccinations. And finally, if you suspected measles in a patient in your office, you should do what?
So this question was not on the poll. We could just go over it together.
Well, the reason I put it on was that I got an urgent message this morning that I had to have a 4th question.
Yeah, thank you.
It doesn't, it's hard sometimes, I think, adding it into the official poll, but if we do the 4th answer this way, everyone will still get credit.
Okay.
I don't know if anyone wants to type their answer into the chat. Otherwise, we can also have Dr. Melish just go over it.
Just a moment. Well, it's not going to do much good at this point to notify the news media. So that will probably happen soon enough. And then you can take advantage of it to give a pro-vaccination answer.
I'm actually quite.
It is important to plan your post-exposure prophylaxis for exposed susceptibles, which may have become infected in your office in the early febrile and non-rash stage of measles. You have to identify who they might be, see that your staff is fully vaccinated or get them revaccinated. Certainly you're going to go to the DOH outbreak control on-call officer when you suspect measles, and so that they can work on the IgM and PCR for you, and you're going to isolate your patient. Okay, so thank you all very much. This is, there have been 2 calls about this from the public health and CDC this year because of the concern about the increasing number of cases in states in which these outbreaks have occurred. And it just shows how we have to have continued vigilance, even when we think we have actually, conquered a disease or brought it under control.
Absolutely. I'm curious if any of our primary care providers have had this experience of having either diagnosed a patient outpatient or later found out that they had a patient who was later found to have measles and had to deal with that exposure in in their office? And if so, if anyone is keen to share that experience, which I can imagine must be extremely stressful, especially in an outpatient setting. And then in the meantime, we do have one final question. One of our participants says that she and her daughter have received the vaccines, but don't, when they check titers, apparently don't have any titers returning. So when they need to provide information for schools, they're having to redo their MMR vaccines. I guess the question is, what could be leading them to be not responsive?
Well, those people may be responsive, but just don't have a titer that's high enough. But there are some people who, you probably are aware of this with many vaccines. We don't generally routinely retest people to see if they're if they have responded. But if you're a known non-responder, a third dose can be given. If there's no response after that, no need for continuing to worry about it. There's nothing more that we have that we can offer. And number two, they're probably immune.
That's good to know. I hope that means that you and your daughter won't have to keep getting vaccine boosters in the future in that case.
Yeah.
Well, thank you so much. This is actually a perfectly timed presentation. We have our next session coming up at the beginning of October. It'll be October 2nd. Dr. Pia Francisca Natalan is going to be speaking about adolescent medicine again. And just a reminder that we are going to be piloting the later time, so start time of 12:30 instead of 12, starting with this upcoming session, October 2nd. In the meantime, thank you so much, Dr. Melish, for joining us and giving us this nice little refresher. I thankfully have not seen any measles in the hospital, at least personally, since I saw that patient with you quite a while back. But it does seem like it's really just a matter of time before we have another kiddo pop up, you know, whether it's in a primary care provider's office or in the hospital. So staying vigilant and as much as possible trying to catch up your kiddos after COVID and everything has gotten in the way of these vaccines. So yeah, thank you so much again, everyone. If there are no more questions for Dr. Melish, I will let everyone go. Thank you so much again. Have a wonderful rest of your week and month, and we will see you all in October at 12:30. Thank you so much.
Bye.
Bye, everyone. Thank you. Bye, Summer.
Hi, thanks you guys.
Thank you.
Mahalo, Dr. Melish.